Hey everybody, welcome back. This is chapter 19, ankle and lower leg. If you're following along, last week we started in with the foot and we're working our way up the kinetic chain. This week's lesson is probably one of the more important ones. They're all important, but this is one that you'll probably encounter more frequently than the others just due to the fact that the ankle is so frequently injured. So just like last time, we will start off by looking at ankle assessment, going through the assessment process, and then looking at conditions and injuries. Unlike the foot, there are a few more special tests that we'll go over this time. As I said before, ideally in a real classroom situation, we would have an opportunity to practice these on one another. So I would encourage you to try these out on a roommate or a spouse or significant other. Do try these out while you in no way, shape, or form would be skilled enough to try these on a patient. I think for most of you, from the sounds of it, you're interested in a career in healthcare. You'll have an opportunity to put these into practice. So this go round, it's really just about learning what the tests are for, how you would do them, and then hopefully in subsequent rounds with other coursework and with other clinical experiences, you'll have a chance to put those in practice and work with a preceptor or a healthcare professional who can help you make sure you're doing them right, make sure that you're interpreting them correctly. So as far as history for ankle and lower leg injuries, we do look at past history. Do they have a history of ankle sprains? We know that with subsequent injury, the risk of re-injury goes up. And every time that happens, the risk goes up again. So that past history is important. The mechanism of injury, whether it's inversion, eversion, rotary component, that's going to identify some prime suspects for us. We'll talk a little bit more about that once we get to the anatomy portion. When does it hurt? Is it an acute injury? Is it something that has just gone on over time that might indicate they've got a stress fracture, something along those lines? Describe your pain. Sharp or dull, constant or intermittent, localized or diffuse. All those descriptors can help us identify the potential source of their problem as well. Do they have any sounds, any crunching, any popping, any sensations? Click, catch, pop, those kinds of things that might indicate they've got a loose body in the joint, or they've got a tendon that's subluxing, something along those lines. If they were disabled, they weren't able to bear weight in the past, how long did that occur? How long until they were able to return to activity? Do they currently or have they had swelling? Do they recall their shoe not fitting appropriately, or other symptoms or signs that they had a significant injury? And then what, if anything, have you done for it? From there, we go into our observations. So again, these are things that we can directly see or measure. We look for postural deviations, look for bilateral symmetry. Genu valgum or verum indicates the alignment of their knee. So with valgum, they would have this knock-kneed appearance, and with verum, they would have kind of this bow-legged appearance. Either of those conditions could potentially predispose their lower leg to problems, and when we get to the knee joint, we'll talk a little bit more about this verum and valgum deformity. Any other obvious deformities that they have, any asymmetries, we'll look at something like a contusion where they've got a large mass where they've been kicked, something like that. We also look at the color and texture of their skin, again comparing bilaterally. Any heat or redness that would indicate they've got an infection or inflammation. Are they in obvious pain? Can they walk without a limp? Is their range normal? We look at all these things even as they're coming into our facility before they even say a word. All right, now once we finish history and observation, we move into palpation. And palpation for the ankle is probably a little bit easier than the foot because the structures are a little easier to identify. We can also generally see the anatomy pretty easily because it's relatively lightly muscled in the area of the ankle. We start working our way up the leg. That becomes a little bit more difficult to do. But when we are palpating, I like to basically start away from the injury and work my way down toward it. That helps prevent the patient from muscle guarding, gets them comfortable with my touch, helps them to feel like I'm not going to go straight to the site that hurts and lead them to kind of clench up on me. So I'll start fibular head and shaft, work my way down the lateral malleolus on the lateral aspect, work my way back up the tibial plateau and the shaft of the tibia. The medial malleolus, usually medial and lateral malleoli, the bony prominences on the ankle. I'll tap on them, make sure they don't radiate pain. For the dome of the talus, I want to plantar flex them fully and basically just palpate in the joint line. And then calcaneus, or the heel, pretty easy to palpate that as well. For the soft tissue, usually I will move them throughout the range of motion and palpate those structures as I'm moving around. Take a look in your textbook, make sure you're familiar with the terms sinus tarsi, sustentaculum tali. Those are two areas that we often will palpate just to make sure we don't have a ligamentous injury or an avulsion fracture. So the sinus tarsi is on the lateral aspect, and that's generally where they're going to hurt if they've got the typical run-of-the-mill lateral ankle sprain. Whereas the sustentaculum tali is on the medial side, and it's just distal to the medial malleolus. Okay. Other soft tissue we palpate, basically all the ligamentous anatomy. I'll usually work my way around as a clock. So you start proximal to the ankle on the lower leg, palpate that anterior tibiofibular ligament. That's what tethers or binds the tibia to the fibula. From there we work our way down to the sinus tarsi to the anterior talofibular ligament. Now that's in the sinus tarsi. That is the most commonly sprained ligament in the body. So if they've got pain there, they've got an inversion sprain, you know they at least have that injury, and you want to see what else they have. Working our way down around the clock at the 6 o'clock position, or 5 or 6 o'clock position, is the calcaneofibular ligament. It prevents inversion as well, but usually with the foot in neutral. Working our way back, we get to the posterior talofibular ligament, and then working our way back up, we get the posterior tibiofibular ligament. So that's all on the lateral side. On the medial side, it's much easier. We just talk about the deltoid ligament. There are specific bands of the deltoid, but they're thick, they're fibrous, it's hard to really differentiate them. So generally we just say deltoid. Easy enough. Okay, for special tests in the foot, or rather in the lower leg, first thing we'll do are percussion and compression tests. These are for fracture. So I could use something like this, which is called a heel bump or heel thud test. I will also do compression tests down. So what I'm trying to do, the tibia and the fibula are parallel to each other. As I compress them together, I'm trying to see, does introducing force into either of those bones lead to pain? So a lot of times if I compress and it hurts away from where I'm pressing, then that may be a positive sign for a fracture. Now on the other hand, if I get pain with this and it just hurts where I'm pressing, then I'm concerned that maybe they've got a contusion or some other soft tissue trauma. So obviously if you have a bruise and you stick your thumb right in it, it's going to hurt. So I'm cautious with that. I also do a percussion test, tapping down along the tibia, down along the fibula. But again, I'm not necessarily looking for pain where I'm tapping, I'm looking for pain that radiates away. If it's where I'm tapping, I'm thinking contusion. If it's away, I'm thinking fracture. Another test we do is called the Thompson test. Here's where we put them on in a prone position with their leg extended, and we squeeze the gastroc soleus, squeeze the belly of the calf muscle, and what you'll see is their foot will ever so slightly plantar flex as long as the Achilles is attached, it's connected. Okay, if there's no movement at the foot, that would be considered a positive Thompson test and would be indicative of an Achilles tendon rupture. A lot of times you can actually see or palpate that as well. Another test we do is called Homan's test, and this is a test for deep vein thrombophlebitis or blood clots. So we'll put them over on their back and slightly flex their hip. We will extend their foot move them into dorsiflexion and basically squeeze their calf. And if they have pain in the calf, that will be considered a positive test for thrombophlebitis. Okay, one of the most common ankle stability tests that we do, so far all we've talked about are pain provocation tests. That's not true, because a Thompson test isn't for pain, it's for structure. But in terms of ankle stability, the ligamentous support of the ankle, one of the ones we do most often is called the anterior drawer test. And you can imagine pulling a drawer open. That's exactly what we're trying to do with this test. So with this test, we put their foot at 90 degrees. This picture's a little misleading. They look a little plantar flexed, but put them at 90 degrees. You can do this either off the table, roll them over on their back, put them off the table with their toes pointed toward the ceiling, or you can put them in a seated position like this. You got to get down low in order to do that. I'll usually put them off the table. The problem with putting them off the table is you're working against gravity. The nice thing about with their leg hanging free is you're able to do that without working against gravity. And so what we do here is we stabilize their tibia and fibula with one hand, we grasp the calcaneus with the other, and we attempt to open that drawer. Okay, and we're looking for stability from one side to the other. If it clunks or you can otherwise appreciate laxity, then that's considered a positive test. Just pain on this one isn't necessarily a positive test. We are actually looking to see how stable that ankle is. Another stability test we do is called the Taylor tilt test, and this one's more for calcaneofibular as opposed to the anterior drawer, which is more for anterior talofibular. So same type of positioning, but instead of pulling up and trying to anteriorly translate the foot, we actually invert the foot. So we stress that calcaneofibular ligament. If we evert and pull their foot out into eversion, we're actually stressing the medial side, and that would be for a deltoid test to see if they've got an eversion sprain. But more often than not, this test is going to be done for inversion. Okay, Klager's test is a stability test. Actually, it's more of a pain provocation test. I apologize. We can't really appreciate how loose the ankle is for this test, and actually what we're testing here is whether or not torsion through the foot causes pain in the distal tibiofibular syndesmosis. Okay, so a syndesmosis, syn means together, desmosis means it refers to the joint structure, so it is a coming together, so it's not a true freely movable articular joint. So where the tibia and fibula are kind of bound together, that's called the high ankle. Okay, so instead of having pain in the sinus tarsi like we have in the case of an anterior talofibular ligament sprain, we actually have pain higher on the ankle joint. So you've probably heard that term before, a high ankle sprain. That is for the anterior tibiofibular ligament and possibly even the interosseous membrane between the two bones. So we can't really manipulate the fibula independent of the tibia, so instead we try to stress it through the Klager test. So if you notice, the examiner has stabilized the lower leg, the foot's pushed up into dorsiflexion and then externally rotated, and what we're trying to do there is cram the talus up into the joint and then essentially wedge or lever the tibia and fibula apart. Now ordinarily that shouldn't cause pain. Our distal tibiofibular ligament should prevent that, but if it's injured or otherwise lacks stability, then that movement will cause pain. Notoriously, these injuries are slow to heal because any kind of rotary component we plant our foot and try to cut away stresses that ligament. There's a number of other functional tests that we can do just to see how the patient is able to move. We would do these all in weight bearing, probably barefooted. We have them walk on their toes to assess their ability to plantar flex. We have them duck walk or walk on their heels to check their ability to dorsiflex. Walk on the borders of their feet, whether it's the lateral borders in inversion or the medial borders in eversion. And we have them do single foot hops to see how functional they are on that injured ankle. We can also put them on a table, run them through passive, active, and resistant range of motion just to see how they're able to function there. And if we find pain with any of these, then we try to corroborate that evidence with our assessment, with our special tests that we've already done, with our history, with our observations, and in order to determine what their condition is. So that leads us to specific injuries. So the sprain is the single most common injury in athletics, and it's usually caused by inversion moments. With eversion sprains, they're not as common, but if we just lump them together, that increases the likelihood of an ankle sprain all the more. Okay. The anterior talofibular ligament is usually injured in inversion, some amount of plantar flexion, and internal rotation. And sometimes it's more than just a ligamentous injury. It's actually an injury to the attachment points where that ligament binds to the bone. Okay. Now we grade sprains on a 1 to 3 scale, same as we do with strains. With an inversion sprain, the foot gets forcefully inverted. This can happen lots of times in basketball. Player comes down from a rebound, they land on another player's foot, and they're forcefully inverted. This may also occur when a patient lands in a hole or they misstep. So this happens quite readily in some sports. Basketball is probably one of the more common ones, but we also see this in pretty much any number of other sports. Okay, with a grade 1 sprain, this is basically some slight stretching of the ligament. In an inversion sprain, it's the anterior talofibular. They're going to have mild pain, mild disability. They may or may not have trouble fully bearing weight. They're usually point tender over that ligament without a positive anterior drawer test. These usually respond pretty quickly, so we'll optimize their loading for 48 hours. Ice compression elevation may also be helpful. We may limit their weight bearing. If they can't walk without a limp, then generally we'll put them on crutches, but more often than not they're just fine. They don't need anything. Tape or brace can provide some additional support, and conservatively, probably the most conservative of conservative, is they're going to return to activity in about a week. I will tell you, in most cases in college basketball, a grade 1 ankle sprain, they're not going to miss any time at all. They're going to be taped, they're going to be braced, and they're going to be back to practice tomorrow, most likely. Maybe a day or two at the absolute most. With a grade 2 inversion sprain, we've got more than just mild stretching. We actually have some tissue damage. We've got tearing of the ligament, but it's still intact. It's still connected from one end to the other, although there's a partial tear through it. Lots of times the patient will describe hearing or feeling a snap or a pop. They'll have moderate pain with weight bearing. They probably aren't able to walk without a limp. They're going to have tenderness and some swelling over the lateral aspect of the ankle as this thing kind of ages out a little bit, especially if they've been on their feet. We'll see this bruising that kind of characteristically settles right near the heel of their foot. They're probably going to have a positive anterior drawer test that would tell us it's an anterior talofibular ligament. They're probably also going to have a positive talar tilt, which tells us probably a calcaneofibular ligament. Again, we're going to modify their activity, treat them for probably 2 or 3 days using police. If it's their first time having this injury and they've got exquisite tenderness, poke around, then they're probably going to be sent for an x-ray. I'd say most grade 2s, especially subsequent re-injuries of grade 2s, we're probably not going to send them for an x-ray. But if we have some concern they've got an avulsion fracture, then we probably will. They may use crutches for a few days, maybe put them in a boot, but we'll progress them to weight bearing just as soon as we possibly can. We want to limit their time in an immobilizer as much as possible. We want to start those range of motion exercises early so that we don't lose range. Taping and bracing can provide some support. They may end up with long-term disability if we don't treat this appropriately. And oftentimes that's irreversible. So we want to make sure we manage this right. And then even once they recover, we're going to want to keep them on a preventative maintenance plan just to make sure that their dynamic support, their musculature, and the muscles that cross that joint are as strong as possible, because once they've lost the static support from the anterior talofib and the calcaneofibular, then really that's our only line of defense, are those muscles that cross the joint. With a grade 3, these are not terribly common, but they are really disabling. This is a complete rupture of at least the anterior talofibular ligament. Potentially others can involve other aspects of the capsule, the calcaneofibular ligament. They're usually going to have a lot of swelling. You'll even see it go down into the toes. They'll have this bruising all along the lateral heel. Positive talar tilt test, positive anterior drawer test. They're unstable and they hurt. This may be a surgical case. We may want to rule out a fracture just to make sure we don't have an avulsion here. They're going to be immobilized for 3 to 6 weeks in most cases. They can do isometrics while they're in a cast, range of motion exercises, progressive resistance exercises, and balance exercises once they get out. If they've had more than one of these, then that's when we start looking at the possibility of surgery. Eversion sprains, on the other hand, we don't see these as often. The medial ligaments are a lot tougher, a lot stronger. There's some skeletal reasons why inversion sprains are more likely. So eversion sprains are far less common, but when they do happen, they tend to be more severe, more significant, because of the fact that the ligaments are stronger, the bone structure is different. To sustain an eversion sprain, and I'm not saying this athlete did, but he's in eversion as he's running, the deltoid can be certainly involved and avulsed. These may take longer to heal just because the injury and the force involved is greater. They may be unable to bear weight. They're going to have pain over the sustentaculum tali, pain over the medial aspect of the ankle. This is going to follow the same course of treatment as an inversion sprain, but even though the events occur in the same order, it may take a little longer to go from one stage to the next. So we want to be cautious here. They may need an orthotic, like we talked about with the foot. May need other things to provide some additional protection. Now, I've already talked a little bit about the syndesmotic or high ankle sprain, but this is an injury to that distal tibiofemoral joint, that anterior as well as the posterior tibiofibular ligament that kind of tethers them together. There's usually external rotation and dorsiflexion. Usually this will occur, they're planted, and there's some sort of rotational component to this. These are notoriously difficult to treat. It's very, very difficult to stabilize these injuries, so there's not really a good tape job or a brace that can protect, unlike an inversion sprain where we can pretty effectively brace them or tape them. This is going to, again, follow that same course of treatment, but it's going to take longer to get through. Another injury is the fracture dislocation. There's a lot of mechanisms for this. We'll see these in motor vehicle accidents. We'll see this patients that plant and cut. We're going to splint these in the position that they're found, refer these. They're going to have to be reduced. I used to have a YouTube video of this, but I don't think it will actually show in the screencast, so I won't show you that. But this is Tyrone Prothrow from Alabama. Once the swelling is reduced, they may be put in a walking boot or walking cast, and then immobilization may last as long as 2 months here. Okay, tibial fractures. We've already talked about the types of fractures that can occur here. Really, the type of fracture is really going to dictate the clinical course that the injury is going to take. If there's a growth plate involved, then that adds a layer of complexity. If there is a portion of the bone that's out of position and we don't get good realignment, then that's going to add some complexity to it as well. So these are not always just reduce and cast. If we can't get a good reduction, then there may be surgery involved with plates or screws or intermedullary rods, just depending on what's involved here. Okay, the Mason-Oeuvre fracture. This results from a rotary component, and instead of it involving the high ankle, the tibiofemoral joint, we actually end up with a fracture. So what we see here is an ankle injury resulting in a high fibular injury. Lots of times they'll have tenderness over the deltoid. They'll also have tenderness over the fracture site. If it tears the interosseous membrane, they may be tender all the way up the lower leg. So with this, compression is going to hurt. Percussion is going to hurt. They're going to have tenderness throughout. Okay, so anytime we've got a significant ankle sprain and they're tender all the way up the fibula, we're going to send them for an x-ray, because chances are it may show up. With an ankle dislocation, posterior dislocation is most common, so you see the foot is posterior relative to the tibia. This can occur from kicking an immobile object, it can occur from lots of different potential mechanisms. Other dislocations we can see, the anterior dislocation, there's a high risk that we've got an avulsion there. A superior dislocation, this usually results from a fall from height where the tib and fib are forced apart. And then with a lateral dislocation, we get a distal fibular fracture, and the talus kind of wedges between. Okay, OCD, we'll talk about this in other body parts as well, but osteochondritis dissecans in the ankle oftentimes occurs in the superior aspect of the medial joint surface of the talus, that talar dome. So if we're looking at the picture here, we would see that in this medial aspect of the talar dome. Here what happens is the articular cartilage is injured, and a portion of it kind of chips away and is moving freely within the joint space. This could result from single trauma. This could result from multiple injuries. Lots of times they'll have pain and swelling. They'll also oftentimes have clicking, catching, or locking as that loose body kind of floats its way around the joint, and maybe it wedges into position or something along those lines. This can be diagnosed through X-ray or MRI. If the fragments are displaced, they're free to move, then usually surgery is necessary, not only to clean out the fragment, but to smooth out the injured bone surface to prevent more fragmentation from occurring. Surgery is going to minimize the risk of a non-union fracture here. An Achilles strain, we see this lots of times in sports. It's going to occur with along with sprains or with excessive dorsiflexion, where we're putting a lot of strain across the tendon. If they're doing a lot of jumping, they may also inflame or irritate the Achilles, but we'll talk about that next. Pain can range here from mild to severe. Most severe injury is going to be a partial or a complete avulsion of that Achilles. So we want to minimize what's causing this to begin with. A heel lift can be used, and stretching and strengthening should start as soon as we kind of get clear of that initial injury phase. All right, that leads us to Achilles tendonitis and Achilles tendinosis. This is a critical distinction that we'll make in other body parts as well, but a true tendonitis, that suffix itis tells us that it's an acute inflammation, is only going to last at most probably 2 weeks, whereas that osis suffix that we see tells us that it's not an acute inflammation, it is rather a degradation. It is a degenerative condition that could go on for months or even years. Okay, so that acute inflammation that involves the tendon, it could involve the tendon sheath or the paratendon, is referred to as tendonitis. That tendon gets overloaded due to extensive stress. This could be from running or jumping. Usually presents with a gradual onset. It kind of hurts a little, and the more I do, the worse it gets. And then we know that decreased flexibility usually makes this condition worse. If we look at this patient, we see this wide kind of bloated looking left Achilles tendon, and we see this curved, narrow right Achilles tendon. So that tells us there's fluid accumulation, there's swelling associated with inflammation here. So they're usually going to present with just some general pain and stiffness. They may have some warmth. If there's an acute inflammation there, then it may actually feel warm to the touch, and there may be some thickening to the structure overlying the tendon. This can limit strength. This may progress to stiffness anytime they're off their feet. So morning stiffness is certainly a common complaint with Achilles tendonitis. They may also have some crepitus. You can think about this if you have a drop of water between your fingertips and you kind of rub it together, that kind of, your fingers don't move smoothly, they kind of grab or catch a little bit, maybe even some crackling or popping. Chronic inflammation can lead to thickening, and thickening isn't good because structurally it's not well aligned connective tissue that has a lot of tensile strength. It's kind of garbage tissue that really lacks a lot of significant strength. So usually these don't respond very quickly. Okay, they're going to be slow healing due to the nature of tendon healing. There's not a massive blood supply here, unlike muscle tissue. So just know you're going to be in for kind of a long haul here. We've got to reduce the stress on the tendon. Whatever started it, we've got to modify. We want to address any structural faults, so orthotics can be helpful. If they've got mechanical issues or flexibility, we can work on those. Anti-inflammatory meds and medications are beneficial, but usually only if this is really an acute inflammation. If it's truly tendinosis, then those anti-inflammatory medications aren't going to help, generally speaking. Cross-fiber friction massage can be helpful. Things like Graston technique. I use a technique called SASTM, which is very similar. Instrument-assisted soft tissue mobilization can help break down that junk garbage tissue that lays in there, restart the inflammatory process, and help the body lay down viable connective tissue again. And then our strengthening needs to progress slowly because we can actually end up re-aggravating that tendon. Okay, in the case of an Achilles tendon rupture, something like this, we said they would have a positive Thompson test. Usually this occurs with a sudden stop and go, forceful plantar flexion with the knee moving into extension. We'll usually see these in older athletes, especially those who have had problems with Achilles tendon pain for some time. They'll usually tell you they thought they got kicked in the leg. They may even be angry because they thought somebody just ran up behind them and kicked them. That immediate pain, especially if we've got a complete rupture, that usually subsides because there's really not any tension on the injured structures. They're going to be point tender. You may be able to actually feel that divot or deformity. They're going to have that obvious indentation there with a positive Thompson test. Most often this occurs just proximal to the calcaneal insertion. Okay, that's kind of the weakest area, a zone of weakness, if you will, proximal to the calcaneal insertion. These are going to generally be managed surgically. They have to be sewn back together, and the longer a patient waits, the harder this becomes to do because that gastrocsoleus complex actually begins to contract, and that distal end starts to move its way proximal up the leg. So the physician actually has to go in, pull it back down, and reapproximate the end so that they can heal. So what you see here is a surgical technique. You can kind of think about this like trying to sew two mops together. It's usually tissue that's damaged, it's degenerated over the years. It's not the most viable, vibrant tissue you're going to find. So these can be difficult to do. They're going to be placed in non-weight bearing, put in a boot. You've seen the little scooters maybe where they're non-weight bearing for weeks and months at a time. There is a non-operative treatment for this, but most of our athletes are probably going to have the repair as opposed to the non-operative. Okay, peroneal tendon subluxation dislocation. Because of the way these PDFs export, you're not going to be able to see this video or click on the link in your PDF, I don't think. But if you just go to YouTube and type in, and actually you can see the URL there. There's actually a video of a patient who has a peroneal tendon subluxation occurring, and as he moves his foot around you can see it kind of snap over. You see here the bloody sock. This was actually a topic of discussion not terribly long ago, but this came to light during, I believe it was the ALCS, maybe the World Series, where patient had this condition and he needed to pitch in Game 6. If you Google the bloody sock, you can read more about this, but really there wasn't time for a true surgical repair. So what they ended up doing here is anesthetizing the area. They actually sutured the tendon to the skin, and he was able to pitch. And the blood you see on the sock is where he was bleeding from the suture sites. Okay, we don't usually do that. In most cases, a snapping peroneal tendon is more of an inconvenience, or it's just kind of an annoyance more than anything. They may get tender, they may be somewhat painful over time, but more often than not, it's just kind of an annoying thing. You can try to tape these with a pressure pad in place. If they continue for a significant period of time, then we can have a surgery done to retether that. But what's happened here is that retinaculum that holds the tendon in place has been ruptured, and the body uses the lateral malleolus as a pulley, and when that retinaculum isn't doing its job, when we plantar flex, it snaps over the bone. So for a pitcher coming off the mound, if they're trying to push off, they're plantar flexing off the rubber, and that would compromise that athlete's performance. Okay, so they're usually going to present with some redness and bruising, ecchymosis, some edema, tenderness, crepitus over the tendon. We will use our conservative approach with compression with a felt horseshoe first. So basically what we do is we tape in a piece of felt that tries to hold that tendon close to the skin, or behind the bone rather. We're usually going to try this 5 or 6 weeks, and then if conservative management fails, we try surgery. Alright, that leads us to anterior tibialis tendonitis. The anterior tib is one of the most powerful dorsiflexors in our foot, ankle, and this most commonly occurs after we run downhill a lot. If you think about what's occurring there, we tend to land with our foot dorsiflexed, and as we are running down the surface, we might heel strike, but then momentum and our body weight forces us into plantar flexion. So even though the anterior tib is trying to hold the foot up into dorsiflexion, it's eccentrically loaded and it's pulling us down into plantar flexion. So that eccentric load leads to irritation. So lots of times we tender over the anterior tib, rest or at least decrease running time and distance that we're running. We want to avoid hill work while we get this under control. In more serious cases, ice and stretch can be helpful after running to help reduce symptoms. Daily strengthening, oral anti-inflammatories like an Aleve or an ibuprofen may be beneficial. Posterior tib tendonitis, very similar, common overuse condition in runners. This tends to be more common in runners who have hypermobility and overpronation in their feet. And what's happening here is the posterior tibialis tendon is contracting to try to prevent that pronation. So this is a repetitive microtrauma issue. So they'll have pain and swelling around the medial malleolus, edema, some point tenderness. It's going to present a lot like your snapping tendon did, but the difference is this is on the medial side, and usually it doesn't snap, it's just tender. We're going to manage this with optimal loading, protection, ice compression, elevation. Our oral anti-inflammatories and analgesics will be beneficial here. This is usually going to be benefited most by an orthotic or with taping. Okay. Peroneal tendonitis, this one looks just like that snapping peroneal, but it doesn't snap, it's just tender. So we'll have tenderness in the area of the anatomical pulley of the lateral malleolus. Usually this is not terribly common, but we'll see this in athletes that have cavus feet due to lots of supination that puts stress on that peroneal tendon. May also have issues with this in an athlete that has a chronically unstable ankle. So management for all these tendon issues is very similar. The question is, where does it hurt? What are we trying to treat? A Lodi tape job, orthotics, either one can help provide some support. Shin contusion, you see this big bruise here. This usually results from a direct blow. They get kicked, or a ball or an implement of some sort hits them. These are usually pretty painful because there's next to no soft tissue overlying the shin. It's relatively poorly protected. They may end up with a big hematoma with jelly-like consistency. The longer we wait, the more likely that is to kind of congeal and coagulate, and makes it impossible for these to be aspirated. Maintaining compression can help prevent that formation of a hematoma. So instead of just leaving it out like this, we would actually cut a felt pad, wrap it tightly, put a compression hose on it or an ACE wrap of some sort. If they're going to try to play with this, something like a shin guard from soccer or a custom-made hard shell pad is going to be necessary here. We do want to monitor for acute compartment syndrome. We'll talk a little bit more about that in just a minute. But if they start to get numbness or tingling out in their toes or compromise in pulse, then those are all warning signs that we need to transport them, get them seen. Muscular contusions, this usually results from being struck or kicked, or like we said, same mechanism, but instead of occurring to the anterior tib, it occurs to the gastroc. Because this is in the muscle belly, then we can stretch to prevent spasm. We can apply cold and compression. As long as this is superficial, they'll usually recover a lot faster than with a shin contusion. A wrap with stretch tape can help stabilize the area. If they cramp or spasm in the lower leg, can be the hardest part on this can be figuring out what's causing it. May be due to fatigue, it may be an electrolyte imbalance or a fluid balance issue. So figuring out how to prevent it can sometimes be a challenge. We want to try to get them to relax as best we can. A gentle stretch to that muscle can be beneficial, but if it's electrolyte in nature, then all the stretching and massage in the world isn't going to solve the problem. We want to push electrolytes. Okay. We can use ice massage to help manage this, but if we don't get to the source, then management can sometimes be a challenge because it just kind of crops back up. Gastroc strain, or soleus strain for that matter, we know that the musculotendinous attachment point is kind of a weak area. This shows a tear to the medial head of the gastroc. We don't see those quite as often as we see damage at the point where the muscle and the tendon come together. We're going to grade strains 1 to 3, just like we did with sprains. This would be an example of a grade 2 strain. They may describe being hit in the leg with a stick, just like we talked about with the Achilles tendon. They thought they were kicked. They may describe that same mechanism. They're usually going to be a little swollen over the spot and tender in that area. Okay, so gentle stretch for grade 1. With grade 2 and beyond, we don't worry about mobility. We focus more on the optimal loading, minimizing the condition. That leads us to shin splints. Medial tibial stress syndrome, MTSS. This is pain over the anterior medial aspect of the shin. Our concern here is that it's not quote-unquote just shin splints, that it's a stress fracture. So we want to be careful here. Could also present a lot like compartment syndrome. Again, we'll talk about that in just a second. Shin splints accounts for 10 to 15% of all running injuries and over half of all leg pain in athletes. And this is a result of repetitive microtrauma. it can involve more severe conditions, but usually with shin splints, MTSS, if we remove the activity, it resolves. Okay, there are 4 grades here where we have pain only after activity, pain before and after activity that doesn't hamper performance, pain before, during, and after activity that affects performance, and pain so severe that performance is impossible. Usually by the time we get to that point, we're really thinking stress fracture. We're going to manage this much the same way an x-ray or a bone scan. Correction of the abnormal biomechanics, usually an orthotic is going to be beneficial here. Flexibility program to increase the mobility of the gastrocsoleus is helpful, and then arch taping can be beneficial too. Now, compartment syndrome, as I've alluded to this twice already, this is not terribly common, but acute traumatic compartment syndrome occurs from a direct blow, so we know we've got a contusion. The question is, do we have something more severe? So what happens here is our lower leg is actually divided into an anterior compartment, a deep posterior compartment, a superficial posterior compartment, and a lateral compartment. So it's kind of an encasement of sorts of the muscle. And what you notice here is within this encasement, we not only have musculature, but we also have veins, arteries, and nerves. Okay, so there's really nowhere for swelling to go in the lower leg but in. So if we get swelling within a compartment, then it's only a matter of time before it starts to squeeze off the vascular and neurologic supply to that body part. So this can be, in an acute case, this can be limb threatening because they're losing blood flow to the distal extremity. So anytime we get a contusion, either a shin contusion or gastroc contusion, we want to monitor and see, do they have numbness, do they have tingling, does it feel like their foot's asleep. In the case of a fracture, we're also looking at this. I think I shared with you my son broke his tibia a couple weeks ago, and one of the biggest concerns they had in the ER was making sure that he didn't have compartment syndrome, because even though the fracture is going to take a while to heal, it's not going to compromise whether or not he has a foot. Whereas if he's got compartment syndrome and they miss it, then it could potentially lead to an amputation. So that's a big deal, and this is one we want to make sure we don't have. Okay, in a severe case, chronic case, they'll typically suggest what's called a release. Okay, so the surgical release, they'll basically do a fasciotomy where that tough fibrous fascia is sliced open. It allows the tissue a chance to move somewhere but in. So if you notice in this picture, we see that the pressure is compressing the vascular structures, and once that fasciotomy occurs, then that pressure is relieved and blood flow is returned. Okay, I've seen runners have bilateral fasciotomies just so that they can continue to participate. Usually the hardest part about that is getting over the initial risk of infection and the pain from the surgery, but usually their symptoms are much improved and they're able to run quite a bit better in a relatively short period of time. Okay, last one is stress fracture of the tibia or the fibula. If we're concerned they have medial tibial stress syndrome, we need to kind of keep this one in the back of our mind as another possibility. Usually runners tend to develop this in the lower third of the leg, dancers usually the middle third. We'll usually see this in athletes who are returning from a long period of disuse or trying to get into shape, weekend warriors. They may have some mechanical issues. This is also a component of the female athlete triad, because this may be an indicator that they have a loss in bone mineral density. So we also want to dig a little bit deeper to see if there's any eating disorder or amenorrhea, things of that nature that might indicate that there's more going on here than just a localized skeletal problem. Usually pain is going to be more intense after exercise than before. They'll have point tenderness. It's usually kind of hard to really pinpoint. This probably won't show up on a regular x-ray. If it does, it's going to take several weeks for that to occur. A bone scan is going to be the preferred method of diagnosis. So this would be an example of an old stress fracture. It's already kind of calloused up. This would be an example of a new stress fracture. So I don't know if we've talked about bone scans in here before, but basically the patient is injected with a tracer dye that is taken up by active bone cells. So if we don't see them anywhere but the growth plates on one side and we see one right in the midshaft, that's an indicator that we've got bone activity going on there. It's an indicator of a stress fracture. Okay, we'll discontinue the stress-inducing activity for a couple of weeks. May put them on crutches. Weight bearing can return when the pain subsides. Usually we'll put them on the bike before we have them impact loading again. Pain-free for 2 weeks, they can gradually return to running. And we've got to figure out what triggered it to begin with. All right, well, that wraps up ankle and lower leg. Tune in next time as we continue making our way up the leg for the knee. I'll see you then. Take care.